In the last session, we are discussing about the pain management and anti-inflammatory drugs. And among the anti-inflammatory drugs, the one thing which we have discussed is the paracetamol and salicylic acid. Acetaminophen and salicylic acid was discussed. The next group of non-steroidal anti-inflammatory drugs. Of course, majority of the all anti-inflammatory drugs, they act through inhibiting the mediators of inflammation. And among those mediators of inflammation, the most important is the COX or cyclooxygenase is a enzyme which is needed for conversion of arachidonic acid to prostaglandin, that inflammatory mediators of inflammation, that prostaglandin. And the drugs which act as anti-inflammatory drugs, majority of them, they would have either direct or indirect action over the synthesis of the prostaglandin. And based upon that, they are mainly categorized into the COX-1 and COX-2 types of that's COX is cyclooxygenase, 1 and 2 types of the enzymes which can be modulated by these drugs. And in general, COX-1 inhibitors, CAPS-1 is responsible for vasoconstriction and prevention of the platelet aggregation, and it stimulates the platelet aggregation rather. COX-2 is a vasoconstrictor and it inhibits the platelet aggregation. That's the primary difference between the two. Now, based upon this, the anti-inflammatory drugs, non-steroidal anti-inflammatory drugs, they are categorized into 4 categories as either non-selective, like aspirin, ketorolac, sulfasalazine, etc. Then the preferential COX-2, like nimesulide, and selective COX-2. Now, whenever we say COX-2 inhibitor, these are the selective COX-2 inhibitors, celecoxib and raficoxib and so on, or COX-3 inhibitors as paracetamol or so on. Now, COX-3 is again question mark, like whether it really inhibits or not is a question mark. But as far as the one basic classification is concerned like almost all the anti-inflammatory drugs would have an activity in synthesis of the prostaglandin by inhibiting the COX, cyclooxygenase, and some of them are non-selective, some of them are selective. So, in general, when we use the term COX inhibitor, it's about the selective COX inhibitors. The others are not really considered as COX-2 inhibitors. The other way classification of NSAIDs are mainly as based upon their chemical combination, like acetic acid derivatives, among them diclofenac, ketorolac, and indomethacin, so on, the other common drugs. And COX-2 inhibitors, among them, the most important commonly used is celecoxib, and phenamates, among them, mefenamic acid is more frequently used. Oxycam derivatives, peroxycam is more frequently used, meroxycam is not that preferable. And in the prophenic acid, ibuprofen or brufen is the most commonly used. The other drugs, phenoprofen, they are the chemical derivatives. Now, the point which we are going to discuss, we will not go into the pharmacology of all, but instead we will take one from each group and then discuss about the basic issues related, very basic, very primary issues related to the pharmacology, and then just go ahead. We will not go into the details of each of these drugs. Now, among them, the first group is a propionic acid group because it's historically the oldest group. See, because among these groups of the drugs, propionic acid groups or drugs are the more commonly used drugs. Among them, the ibuprofen, or what we call as the brufen, is the common drug, and we discuss about this. It's an anti-inflammatory and analgesic, is associated with it's also having some impact with the corticosteroids, similar to that of the corticosteroids. Without the adverse effects of that corticosteroids, it reduces the inflammatory pathologies, and it inhibits the prostaglandin synthesis. And COX-1 and 2 are non-specifically inhibited. It's a non-specific inhibitor of both COX-1 and COX-2, and usually it's administered by oral route, and even taken with the food, it can it can be absorbed. Absorption from the gastrointestinal tract is quite defendable, and excretion occurs to the liver, and metabolism occurs to the liver, and excretion occurs to the kidneys. Of course, it's a relatively mild pain reliever, or reduces the pain mildly, and it's an effective anti-inflammation. The anti-inflammatory drugs. Very specific in case of the primary dysmenorrhea pain. Spasmodic pain produced the dysmenorrhea is very specific as such. Then contraindications are patients who have allergy, it should not be administered, like sulfonamides and so on. And patients with the cardiovascular pathology, renal or liver dysfunction is contraindicated. And it should not be given with the thrombotic, in the patient who have thrombotic events, like patients who have cerebrovascular accident like conditions, it should not be given. Pregnancy and lactation also, it's not to be given. When it is given with the diuretics like furosemide, the action would be reduced. Beta blockers would increase the toxicity of the cardiac toxicity of the ibuprofen. And if it is administered along with the lithium, the toxicity, lithium is an antipsychotic drug, it also becomes quite toxic as such. And it should not be given with the anticoagulants or after ethanol injection, consumption, like alcohol consumption as such, because it can produce either bleeding or liver disorder. The commonly seen adverse effects are headache, dizziness, and hypertension, and even cardiac failure edema can occur quite frequently, and nausea, vomiting also can occur in such conditions. Uh, Steven Johnson syndrome comparatively less common in these conditions. Anyway, that's about the one of the groups of the drugs, propionic acid. One example is the same. Now, among the acetic acid group, so I would prefer diclofenac sodium. Diclofenac sodium also is having a similar activity of inhibiting COX-1 and COX-2, non-specific, non-selective inhibitor, and has a potent inhibitor of prostaglandin synthesis. And the common indications are the same, like pain, particularly acute gout condition, it's very specifically used. And in case of deep-seated pain like arthritis conditions also, and musculoskeletal disorders, is preferable. It's more potent than ibuprofen, and it's also specifically indicated in case of rheumatic diseases and postoperative pain. Of course, you see that it's quite frequently used in our setup also, where we use this as a postoperative analysis, quite frequent. And it also has a mild antispasmodic activity, and hence even in case of colicky conditions, diclofenac is indicated to a to a certain extent. Common adverse effects are comparatively, compared to other non-inflammatory drugs, non-steroidal anti-inflammatory drugs, is less these occurring, like side adverse effects are comparatively lesser and milder. But whenever they occur, they are commonly appetite reduced being, diarrhea, dizziness, gastrointestinal discomfort are the most common abnormalities or symptoms produced as adverse effects as such. Then edema, vertigo, vomiting can also occur. Rare, very rare conditions are acute kidney injury, chest pain, heart failure, myocardial infarction, palpitations also can occur very rarely. This in the pregnancy is contraindicated. Unless there is a very significant indication, diclofenac is contraindicated in pregnancy. And the other contraindications are in the patient who is having a dehydration, patient who have a history of chronic bronchial pathologies like asthma, and cardiovascular bleeding, if the patient has a cardiovascular bleeding or hemorrhagic conditions, hemorrhagic pathologies, it's better not to be used as such. That's about the use of diclofenac as a analgesic in common conditions. Then the more specific, the COX-2 inhibitors. Now, these days, COX-2 inhibitor at one stage, COX-2 inhibitors were very popular. Now they are not so popular. Of course, now with the dosage, with the ibuprofen, the dosage is 50 milligram and up to the maximum of 300 milligrams, whereas diclofenac is 75 milligram up to the dosage maximum of 300 milligram. Now, with the celecoxib or the other way, which is the most commonly used drug, and now it is less popular. Earlier it was very popular. Now these drugs have become less popular because of the adverse effects. The commonest adverse effect of all these COX-2 inhibitors, specific COX-2 inhibitors are it can produce heart failure, cardiac load, and hypertension, and hence it's now becoming less popular. But earlier, at one stage, like a few years back, they were considered as the most efficient drugs in the management of arthritis-like conditions, osteo and rheumatoid arthritis conditions. They were the drug of choice at one stage. Now it's not. It's not preferred because of very frequent adverse effects, and in certain Western countries, it's already banned. COX-2 inhibitors like celecoxib is already banned, but in India it is still available. Anyway, that's about one group of the drug. So that's about representatives of non-steroidal anti-inflammatory drugs as a group. The next part of the analgesics or pain management is opioids are derivatives of opium. Now, derivatives of opium also are quite variety are there in the market which are available. And again, we will not go into the detail of all that. Just casual reference. Among the opioid compounds which are naturally available, morphine, codeine, thebaine, and papaverine. Now, morphine is analgesic. Codeine, more than analgesic, would be antitussive because it depresses the respiratory center. Activity of the respiratory center is reduced, and codeine is now more frequently used as an antitussive. Papaverine has a smooth muscle relaxant property, and hence it's more preferably used as a smooth muscle relaxant than analgesic. Though all the drugs would have some amount of analgesic activity. Then other compounds, episynthetic compounds like diamorphine and dihydromorphine and buprenorphine, these are now more used as addicting drugs, and hence they are not generally clinically used as the analgesics because of the possibility of addiction being more frequent, and the sale of these drugs also is well controlled, very controlled. You cannot just prescribe these drugs easily. But in very specific conditions, like a pain produced due to malignancy in a terminal patient, still these could be used as a drug treatment. And because of their cycle effects on the mood, increasing the mood, improving the mood as such, they are now used as psychoactive substances, and they are now of interest in case of these drug addiction and de-addiction issues. The most frequently used clinically used drugs are petidine, fentanyl, the derivatives of the same, which are often used in the clinical practice as analgesics. Then methadone also is used. Fentanyl and remifentanil are also occasionally used as such. The most frequently used drug is fentanyl and petidine in the routine clinical practice. Now, as far as the general dosage of these drugs, particularly the drugs which we use frequently, I refer to these only. Morphine is used either orally or by rectal or subcutaneous injection, IM or IV. And whenever the usual dose is 4 to 10 milligram when it is given parenterally, and 30 milligram when it is given orally. Codeine, is a antitussive more than analgesic, and usually 30 milligram to maximum of 300 milligram, not less, more than that. Fentanyl is again quite frequently used in the clinical practice. Uh, it's, and it could be used by IM or IV route. The dosage is 0.5 milligram to 0.5 to 1 microgram per kilogram body weight if it is given IV or IM. Whereas when it is given transdermal, the dosage is higher, 12 micrograms to 100 micrograms per hour it could be given transdermally. Now that's about the usual dosage. Fentanyl is quite frequently used in the clinical practice. Then hydromorphone, which is not so frequently used, it could be given by oral route at the dose of 4 to 8 milligram, rectal route at 3 milligram, and subcutaneous parenteral would be 1.5 milligram as such. That's the usual dosage, maybe increased if necessary. Then oxycodone is usually given by a oral route, and it's a 5 milligram to 10 milligram is the usual. The most common adverse effect of all these, again to make it very simple, I will not go into the details of each of these drugs. In general, all the opioids would have the adverse effect, and most important adverse effect is the dependency. Once you start with this opioids and give it for a certain period, then the patient they tend to become dependent, and hence a sort of addiction formation is one of the most serious critical issue with the opioid drugs, and hence it has to be given carefully. The other common adverse effects are vomiting, constipation, sedation, suppression of the cough, because it can be a adverse effect in the patients under anesthesia or after the postoperative period, because if the cough is suppressed in those, there is a high risk of aspiration, and hence codeine or morphine derivatives are to be used very carefully. If at all there is a possibility of vomiting in a patient after that, then better to avoid this morphine. And if at all morphine is given, because vomiting is a very frequent complication, so you need to be careful about the cough issue. So it's a very critical issue. So when to give morphine as a postoperative drug or not, and if you give morphine as a postoperative, a continuous monitoring is absolutely necessary. The other adverse effects are pruritus, itching can occur, dry mouth and bronchoconstriction, respiratory depression also can occur, delirium, seizures also can occur in such conditions. Uh, the morphine is a drug of choice in case of pulmonary edema produced due to myocardial infarction. But at the same time, if some other patients they were otherwise normal, there could be a pulmonary edema induced due to stasis of the circulating blood in the lungs. It's non-cardiogenic pulmonary edema. Now that's a paradoxical issue. A myocardial infarction induced pulmonary edema, morphine is the drug. Whereas in other conditions, it can produce a pulmonary edema as a complication, but that complication of pulmonary edema is a temporary, transient, but it still can occur as such. So that's about the common adverse effects of the morphine. The next aspect, the other aspect of the pain management is administration of counter irritants. Counter irritant is an agent which produces a pain sensation on the surface of the body, and because the pain is felt on the surface of the body, the pain receiving center in the higher area would be confused about the localization, and hence it gives a false sense of relief. That's what we call as a counter irritants. That kind of a mechanism of pain control is not really pain relieving. It's only that the person would be feeling less intense pain. And that is a technique. And most of these our sweeteners, oils, and so on, which we use, are these volatile oils, which are used quite frequently, liniments, which are used regularly. Majority of them, they would have a similar activity, concomitant activity, all that your these liniments like your sanguinil and so on, and so many of those drugs which are quite frequently used in anti-inflammatory, and then when you administer them and then apply a heat, the steam, it acts as a this counter-irritant in the sense it produces a sensation of pain over the surface of the body. Now, if we apply those liniments which are available in the market, which are frequently sold in the market, if you apply it over the normal surface, you will feel that burning sensation. But when a patient has a deep-seated pain, then there may be relief, and this relief is due to a false sense of localization in the brain, in the assets. So, along with so-called all that Ayurvedic oils which are used quite frequently, which are primarily counter-irritants, there could be many other drugs which are used also, and even NSAIDs like diclofenac, or even these morphine or clonidine also often is used as this surface irritant localized is locally used as. There are now many of such ointments and liniments are available in the market which relieve the pain. All of them are counter irritants, and one of the advantages of the counter irritant is the other than the local adverse effect like skin allergy, there may not be any systemic adverse effects. Comparatively, the systemic adverse effects are lesser. But the major disadvantage would be it's not a real relief of the pain, it's only a false sense of relief of the pain. So, if the damage produced due to the disease is continuing and it's not controlled, because of that false sense of the relief of pain, patient may hurt himself, and hence it's not a drug of choice, but in certain critical conditions, it can help the patients have a better quality of the life. Then the others drugs which are used the pain management are the spasmodic or antispasmodics. The another very common cause for the pain is the spasmodic pathology of luminous organs, like it could be the intestinal colic, ureteric colic, and so on. Now, in such conditions, the usual NSAIDs would be having less effect. Not that they would not have any effect. The NSAIDs like diclofenac can be given, but will not have a very specific effect because the mechanism of the pain there is due to the spasm, rigorous movement of the smooth muscles and constriction of the smooth muscles, that there would be pain. So relieving of the spasm also can relieve the pain. And again, spasmodic antispasmodics could be of two categories: antispasmodics which release the or relax the smooth muscles, and then the skeletal muscle relaxants. Smooth muscle relaxants are often used in case of the colicky pain of the gastrointestinal tract, like these intestinal colic and so on. And among them, anticholinergics are quite frequently used as such. Quite frequently used relaxants are one directly acting or anticholinergic. Directly acting like papaverine is directly acting over the muscles. Anticholinergics like atropine and atropine derivatives are used as a antispasmodics which reduce the cholinergic activity. Common adverse effects of these direct acting drugs are nausea, dyspnea, and itching, so on. And particularly, patients who have already a tendency to have paralytic illness, it should not be given. So, if at all you prefer papaverine like drugs for reducing the colic pain, you should be very sure that it's not a intestinal obstruction that paralytic illness would occur, because it can enhance. Whereas anticholinergics like atropine derivatives, they can be used in such conditions, and the adverse effects among them are blurred vision quite frequently, urgency of urine and retention of urine also is quite common, and constipation is the next common. Others are not comparatively not so frequent, and it should be used in children and very old patients carefully, because there is a possibility of a sudden blockade of the cholinergic activity, and hence the patient may go into shock. So atropine like drugs are not very specific, or should not be freely given in children and very elderly old patients. And again, patients with the cardiac pathologies, gastroesophageal reflux disorders, it should be given carefully. And in patients with myasthenia gravis, it can aggravate the symptoms. Of course, in myasthenia gravis diagnosis also, anticholinergics are used often as a test drug. Like when you give anticholinergic drugs, the condition worsens, then you diagnose this as a myasthenia gravis. Then comes the skeletal muscle relaxants. Skeletal muscle relaxants are more frequently used in anesthesia than really the pain management. But in the pain management too, many of these skeletal muscle relaxants are used to reduce the musculoskeletal pain. When they are applied more frequently, they are used for local uses, where it's applied over the surface of the body, so that would reduce the pain. Whereas systemic use of the skeletal muscle relaxants are used during anesthesia, because one of the important issues is whenever you use the skeletal muscle relaxants directly, parenterally in high doses, the respiratory muscles also will go into relaxation or spasm, and hence you need to use a respiratory support. So patients under anesthesia in the OT are in such acute tetanus-like conditions, because you have a ventilatory support. Only with the ventilatory support, the skeletal muscle relaxants are given. So like tubercularium or curarium, myocurarium, which are used as a skeletal muscle relaxants. Again, the skeletal muscle relaxants are categorized into two: non-depolarizing and depolarizing. These depolarizing are succinylcholine. Now, their pharmacology is a part of the anesthesia subject, so I will not go into that part now. Maybe later on some other occasion we can think of that. Now, but these are to be used during anesthesia, and every time you use these drugs, it's absolutely necessary that you have to have a ventilatory support. Whereas the cyclobenzapine, which is or baclofen, these can be used as directly in the clinical practice to reduce muscle. Diazepam, which is a muscle relax, which is actually a sedative uh, and tranquilizer, also is a muscle relaxant due to its CNS action. And local muscle relaxation activity will be by the dantrolene. Dantrolene is again quite frequently used in many of these ointments which are used in the chronic pain conditions, and this would reduce the skeletal muscle tone. Now, spasm of the skeletal muscle itself can be a cause for the pain in such conditions, particularly in trauma. Patients with the trauma, along with the tissue damage, spasm of the muscles can be a factor which aggravates the pain, and in such conditions, muscle relaxants applied can be reducing the pain to a certain extent. Now, many of the other skeletal muscle relaxants, again, a few more of the commonly used skeletal muscle relaxants. I'm just having a list of that. Again, we will not go into all that detail. You may see these drugs being used in the market quite occasionally, and the only thing is, majority of them, or rather all of them, they are now frequently used only for local uses like acute muscles pain or spasm conditions. Rarely they are given parenterally, except maybe these yeah yeah cyclobenzapine, which is maybe given parenterally. Other drugs are quite frequently used as a local applicants, and major main purpose of keeping this list here, referring to this is, if you look at many of these locally used ointments or liniments, you may see these names, and these are simply chemical variants of the same skeletal muscle relaxant groups. So we are not going to the detail of these issues. Now, lastly, last part of this would be the pain management. A patient coming to you with the acute pain, what should be prepared and how to go for the selection of the drugs, because you have many choices. Like when it is a pain patient is produced due to a known cause and it's localized, and the local trauma is the cause, tissue injury is the cause. Many of the local management like heat and cold, which we have discussed, could be the choice. If it is not enough, then you start with the usually mild analgesics like these paracetamol like drugs. If it is not enough, then you go for the specific anti-inflammatory drugs or non-opioid drugs like NSAIDs. They are preferred. If it is still persisting, then only the opiates are given. Opiates are never given as the first choice. So these could be combined. Opiates may be combined, or steroid, non-steroid drugs also could be combined with other drugs, or more than one drug could be given to reduce the pain as such. So that's how the general approach to the pain management. It's not that you start with the strongest opioid as in the beginning, and as such. That's the one of the important issue which you have to keep in mind. Then another issue with the is opioids, with the particularly the opioids is when you use the opioids frequently, in due course of time, the patient would have a rather adaptation. The pain really would be lesser. Effect would be lesser. If it is administered for a long time, the effect of the pain will be lesser, and hence. And another important is there is always a possibility of overdosage. And for the pain management, now one of the other technique which has become quite popular is a patient controlled administration of the drugs. Like, see, the one major problem with the pain management is there is no objective method of assessing the dosage required for the pain management. Severity of the pain, assessing the severity of pain also is subjective by looking at the facial expression, and even the dosage of the pain relieving drugs also are somewhat vague, and hence the other way of making reducing these adverse effects of the drugs and making that pain management safer would be a patient controlled administration, because you give the control to the patient, and the patient can feel the pain, and whenever the patient can feel the pain, he can switch on or switch off that. So newer techniques of such patient controlled administration are coming up, and one of them is the common patch administration of the patch over the surface of the body with a positive current, iontophoresis. That technique is called as iontophoresis, where you will apply a patch of the drug over the surface of the body, and then there will be some switch like control. Whenever the patient feels the pain, he can switch on, and once the patient feels sufficient relief of the pain, he can switch it off. So that kind of a technique is the technique of the future, and in due course of time, it may become quite popular and quite regular. Uh, that's about the pain management in general. With this, we conclude today, and we conclude the chapter of emergency medicine. Uh, for next, whatever is your choice, you have to decide. And if you decide that if there are any subject needed, we will continue. If there are any questions, I'll try to answer the questions, and then we'll wind up today. Right? There are no questions. Right. So, right, we'll
Thank you, sir.
conclude today. But emergency medicine chapter is over. Next part, you have to decide. Like, that should be the topic that you have to decide. Right.
Yes, sir.